You know, sometimes the most descriptive medical terms come straight from the language itself. Take angina pectoris. Okay, let's unpack this. Angere in Latin means to strangle, right? And pectus means chest. So literally it's a strangling of the chest. And I mean, when you understand what's happening, that feeling of tightness and pain, that vivid image, really hits home.
It really does. Angina pectoris, well, at its core, it's chest pain signaling that the heart muscle isn't getting enough blood flow.
Right.
A condition we call ischemia, which basically just means a lack of oxygen. It is that feeling of the heart being, strangled by this deficiency. And for this deep dive, we're going to explore the three main types of angina: stable, unstable, and vasospastic, which is also known as Prinzmetal angina.
Exactly. Our mission here is to really get under the skin of these distinctions. Like, what causes each type? What do they mean for your heart health? And ultimately, to give you, the listener, a much clearer understanding of this really important area. So let's start with the most common one, stable angina. What exactly is going on there?
Okay, stable angina. Sometimes it's called chronic angina. This is the type that typically shows up, during exertion or times of stress.
Like exercise.
Yeah, think about it. You're exercising, climbing stairs, maybe going through a particularly tense situation at work. That's when the pain hits.
Okay.
But the key thing here is that it usually subsides when you rest.
Okay, so what's the underlying cause in these situations? Why does it happen then, but not usually at rest?
Well, in the majority of cases, the culprit is atherosclerosis.
Plaque buildup.
Exactly. This is where plaque, it's a buildup of fatty substances, cholesterol, other cellular waste. It builds up inside the coronary arteries. Those are the vessels supplying blood to the heart muscle.
Right.
With stable angina, there's usually a significant narrowing. We're talking about 70% or greater stenosis.
70%.
Yeah, stenosis just means a narrowing of the artery by at least 70% of its opening because of this plaque.
Wow, 70%. That sounds like a lot.
Yeah.
So how does that work with the pain only happening sometimes, if it's that blocked?
Well, that reduced opening might be just enough to supply the heart with the oxygen it needs when you're, just sitting around at rest.
Okay.
But here's where it gets interesting. When you exert yourself or experience stress, your heart has to work harder.
Right, it needs more fuel.
It beats faster, pumps more blood, and therefore needs more oxygen. That narrowed artery, which was maybe okay at rest, just can't deliver enough oxygen to meet that increased demand. And that leads to the pain of stable angina.
Yeah.
It's kind of like trying to breathe through a really narrow straw when you're running.
That makes perfect sense.
Yeah,
like trying to water a big garden with a hose that's mostly kinked shut.
Precisely. And it's not just about blocked arteries either.
Oh.
Any condition that causes the heart muscle itself to thicken can also lead to stable angina because, a larger, thicker muscle simply requires more oxygen to function.
Okay, like what sort of condition?
We see this in conditions like hypertrophic cardiomyopathy, that's often genetic, or in cases of aortic stenosis, where the aortic valve narrows, forcing the heart to pump against higher pressure.
Right.
Even hypertension, high blood pressure, can lead to this thickening over time.
So the heart's working harder, demanding more fuel, but the delivery system, the artery, is compromised somehow, either blocked or the demand is just too high.
Exactly.
Now, when this oxygen shortage, this ischemia happens, what's actually going on inside the heart muscle itself?
Okay, so if we look at the heart wall, it has three layers. There's the epicardium on the outside, the myocardium in the middle, that's the actual heart muscle, and the endocardium on the very inside. Now, the coronary arteries, they start in the epicardium on the outside, and then they branch down to supply all the layers. When blood flow is reduced, or like we said, the heart muscle is thicker and needs more oxygen, the deepest layer, the one just beneath the endocardium, we call it the subendocardium. That's the most vulnerable.
Why that layer specifically?
Think of it like the heart muscle is a layered cake. The bottom layer, the subendocardium, is furthest from the icing, the direct blood supply coming from the outside. So it's the first to dry out when resources are scarce.
Okay.
So the classic finding in stable angina is subendocardial ischemia, meaning that area isn't getting enough oxygen, especially when demand increases.
Okay, so the subendocardium is the first to feel the pinch, and this lack of oxygen, that's what triggers the pain, right?
Exactly. The ischemic tissue, the tissue starved of oxygen, releases certain molecules like adenosine and bradykinin.
Okay.
These substances then stimulate nerve fibers in the myocardium, and that stimulation translates to the sensation of pain we recognize as angina, that strangling.
And how would someone describe this pain? What does it actually feel like?
Typically, it's described as a pressure or a squeezing sensation in the chest, that strangling feeling we talked about at the start. It can also radiate, spread, often to the left arm, but also sometimes to the jaw, shoulders, even the back.
Okay. Any other symptoms?
Sometimes, yeah. People might also experience shortness of breath and sweating, which we call diaphoresis.
Right.
But like we said earlier, the key with stable angina is the pain, and these other symptoms usually don't last longer than about 20 minutes. And crucially, they tend to go away once the exertion stops and the heart's oxygen demand decreases.
All right, that paints a pretty clear picture of stable angina. Predictable, related to exertion, relieved by rest. Now let's move on to unstable angina. The name itself suggests it's, less stable, a bit more serious.
You're absolutely right. The crucial difference with unstable angina is that the chest pain can occur even when you're at rest.
Oh, okay.
It's not only triggered by exertion or stress. And unlike stable angina, the pain doesn't reliably go away with rest. It's more persistent, more unpredictable.
So even when the strangling isn't being actively provoked by exercise, it can still happen.
Exactly. It happens because of this unstable situation in the arteries.
And what's the typical cause behind this more unpredictable pain? Is it still the plaque?
It usually is, but there's a twist. The primary culprit in unstable angina is usually the rupture of an atherosclerotic plaque.
The plaque breaks open.
Yes. And when this plaque ruptures, it triggers the body's clotting system. You get the formation of a blood clot, a thrombus, right on top of that ruptured plaque.
Oh, okay.
Now, while this clot might not completely block the vessel, it significantly narrows the already compromised artery even further.
So even less room for blood flow.
Right. Which means the heart tissue can start to feel oxygen-starved, even when the heart is just pumping at a normal resting rate.
So similar underlying issue, the plaque, but a more acute event happening. The rupture and the clot formation. Does that mean the impact on the heart muscle is different too?
Well, interestingly, unstable angina also typically involves subendocardial ischemia, just like stable angina.
Oh, still the inner layer.
Yes, that deeper layer of the heart muscle is still usually the most vulnerable to the reduced blood flow. However, the critical distinction and what makes unstable angina so dangerous is that while the heart tissue is definitely ischemic, it's not getting enough oxygen, the cells haven't started to die yet.
Okay.
This is what differentiates it from a myocardial infarction, a heart attack, where actual tissue necrosis or cell death has begun.
Okay, that's a really, really important point. The cells are alive, but definitely in distress. So why is unstable angina considered such an emergency then, if the cells aren't dead yet?
Because it signifies a highly unstable situation within those coronary arteries. The presence of a ruptured plaque and a forming blood clot means there's a very high risk of a complete blockage occurring very suddenly.
Right, the clot could get bigger.
Exactly. And that can quickly lead to a full-blown heart attack, where the oxygen deprivation becomes severe and prolonged, causing irreversible damage, cell death to the heart muscle. That's why unstable angina needs immediate medical attention. It's like a warning sign that the dam is about to burst, potentially cutting off the vital supply completely.
That makes perfect sense. It's a major red flag.
Okay.
Now, let's talk about the third type, vasospastic angina, sometimes called Prinzmetal angina. This one sounds different again, just based on the name spastic.
It is quite distinct, yeah. In vasospastic angina, the chest pain isn't primarily due to a fixed narrowing from plaque buildup, although, atherosclerosis might also be present. It's not the main driver here.
Okay, so what is?
Instead, the ischemia and the resulting chest pain are caused by coronary artery vasospasms.
Spasms, like muscle cramps.
Sort of. Imagine the smooth muscles that are part of the artery wall suddenly and intensely constricting, just clamping down, squeezing the artery shut or nearly shut, and drastically reducing blood flow.
Whoa.
It's like someone suddenly clamping down hard on that garden hose we mentioned earlier.
So it's more of a temporary involuntary tightening of the blood vessel itself, not necessarily a physical blockage inside.
Yeah.
Wow, that is a completely different ballgame. It sounds almost more alarming because it's so unpredictable.
Exactly. And this is why the episodes of vasospastic angina don't typically correlate with exertion. They can happen at any time, including when you're completely at rest, which makes them, as you said, quite unpredictable.
And what triggers these sudden spasms?
Yeah.
Is that well understood?
The underlying mechanism isn't as fully understood as atherosclerosis, honestly. but it likely involves an overactivity or imbalance of certain substances in the body.
What?
Possibly vasoconstricting substances, things that cause blood vessels to narrow, maybe like platelet thromboxane A2.
Yeah.
Something causes the smooth muscle in the artery walls to contract abnormally and intensely.
That's fascinating. So instead of a physical blockage like plaque, it's more of a functional issue with the artery itself reacting badly.
You could put it that way, yeah.
Does this lead to a different pattern of ischemia in the heart muscle compared to the other two types?
Yes, it generally does. Because the entire artery can constrict severely, the reduction in blood flow affects all layers of the heart wall supplied by that specific artery.
All layers, from outside to inside.
Correct. This is referred to as transmural ischemia. Trans meaning across, mural meaning wall. So the oxygen shortage spans from the epicardium through the myocardium all the way to the endocardium.
Wow.
Which is quite different from the subendocardial ischemia we typically see in stable and unstable angina, which primarily affects just that inner layer.
Okay, so imagine the blood supply being cut off to the entire thickness of that part of the heart wall, like squeezing a tube completely shut.
That's a good way to think about it. It affects all the layers from outside to inside in the area supplied by that spasming artery.
Okay, so we've covered the three main types. Let's try to maybe draw out some key similarities and differences now, just to really solidify this for everyone listening. What's one important thing to remember that applies to all three?
I think it's crucial to remember, and we touched on this, that in all three types of angina, the injury to the heart muscle cells, the cardiomyocytes, is reversible.
Reversible.
The cells are experiencing a lack of oxygen, yes, but they haven't died. This is the absolute key distinction between any form of angina and a myocardial infarction, a heart attack, where cell death does occur.
Right.
So while that strangling sensation is a serious warning sign, the heart muscle in angina hasn't yet suffered permanent damage.
That's a vital point. So the damage isn't permanent in angina itself. Now, what about what we might see on an ECG, an electrocardiogram, that test that measures the heart's electrical activity? Are there typical differences there?
Yes, definitely. There are often telltale signs. In stable and unstable angina, because the ischemia is typically limited to that inner layer, the subendocardium, the ECG often shows something called ST segment depression.
Depression. Okay.
However, in vasospastic angina, because of the transmural ischemia affecting all layers of the heart wall,
Right, the whole thickness.
the ECG typically shows ST segment elevation.
Elevation.
That is a really important diagnostic clue for doctors trying to figure out what's going on.
That's a really helpful distinction.
Yeah.
ST depression versus ST elevation. And we've already touched on this quite a bit, but just to summarize, how does rest factor into relieving the pain for each type?
Right. So rest is usually effective in relieving the pain of stable angina because resting reduces the heart's oxygen demand.
Makes sense.
However, with unstable angina and vasospastic angina, the pain can occur even at rest. It's not reliably relieved by just stopping activity.
Okay.
In unstable angina, that's due to the ongoing issue with the ruptured plaque and clot reducing flow, even at baseline. And in vasospastic angina, it's because those artery spasms are unpredictable and not necessarily tied to exertion levels.
Got it. And finally, what about treatment? Are there any common threads or maybe specific approaches for each type?
Well, a common medication used for all three types of angina is nitroglycerin.
Nitroglycerin.
Yeah, this is a vasodilator. It helps to widen blood vessels.
Opens them up.
Exactly. Allowing for potentially increased blood flow to the heart muscle and easing that feeling of constriction or strangling.
Makes sense.
Now, in addition to nitroglycerin, vasospastic angina, because it involves those muscle spasms,
Right.
it often responds particularly well to medications called calcium channel blockers.
Yeah.
These drugs help to relax the smooth muscles in the artery walls and prevent those coronary artery spasms from happening.
Interesting. So targeted treatment based on the mechanism.
Precisely.
So we've really taken quite a deep dive into these three phases of angina pectoris. And, to reiterate, while all of them are absolutely warning signs of a problem with blood flow to the heart, understanding these nuances seems so important. When the pain strikes, is it during activity or at rest? What's the likely culprit? Is it a fixed blockage, an unstable plaque, or a sudden spasm? And how deeply is the heart muscle affected? Just the inner layer, subendocardial, or the whole thickness, transmural? These are all critical pieces of the puzzle, aren't they?
Absolutely. Recognizing these different symptom patterns and understanding their potential underlying causes is really the first crucial step in seeking the right medical attention.
Yeah.
And especially with unstable angina, as we stressed, The emergency nature cannot be overstated. Getting a prompt diagnosis and treatment is vital for preventing more serious events like a full-blown heart attack.
This has been incredibly insightful. It really makes you think, doesn't it? About how different triggers exertion versus just resting, and different underlying mechanisms like a physical narrowing versus a sudden vessel constriction can both lead to the heart signaling distress with that very kind of primal feeling of being strangled.
It really does highlight the complexity.
It highlights the dynamic and complex nature of our cardiovascular health. Something for you, the listener, to really mull over how these different signals from the heart, these different types of angina, really underscore its constant need for a delicate, ongoing balance between oxygen supply and demand.